Functional hypothalamic amenorrhea, or FHA, is a reversible condition resulting in infertility related to hormone dysregulation. Primary amenorrhea describes absence of a first period, while secondary amenorrhea is the absence of a period any time after menarche but before menopause. FHA is responsible for approximately 20 to 35% of amenorrhea cases. It affects over 1.62 million women in the United States and 17.4 million women worldwide. FHA is related to altered secretion of gonadotropin-releasing hormone from the hypothalamus, causing decreased release of follicle-stimulating hormone and luteinizing hormone from the anterior pituitary, which prevents the production of estradiol by the ovaries. Any stressor that activates the hypothalamic pituitary axis can cause energy to be diverted from reproductive function. Stressors related to FHA are characterized as weight loss-related, stress-related, and exercise-related. While these have been identified as the general causes of FHA, there are many complicated physiological changes associated with FHA that have not been fully defined. FHA is most common in athletes in sports such as figure skating, ballet, and long-distance running, in which low body weight is associated with increased performance. Women also have variable intrinsic susceptibilities to FHA, which may be linked to rare gene variants. FHA diagnosis is made based on the following criteria, all of which must be met: amenorrhea for 3 or more consecutive months, estradiol less than 50, FSH less than 10, LH less than 10, and exclusion of other etiologies such as thyroid dysfunction, hyperprolactinemia, premature ovarian insufficiency, and polycystic ovary syndrome. The most obvious immediate consequence of FHA is infertility. Infertility resulting from FHA is usually reversible, but recovery and restoration of fertility can take months or years. FHA can also lead to atrophy of the uterus in adult women and delayed menarche and impaired development of sex characteristics in girls affected during puberty. Additional health consequences include increased risk for cardiovascular disease, osteopenia or osteoporosis, and psychological disease. Currently, the primary treatment recommendation is to correct any energy imbalance, which usually requires behavioral change and weight gain. This is accomplished through increased energy consumption and/or improved nutrition and/or decreased energy expenditure. Psychological support, specifically cognitive behavioral therapy, has been shown to be an effective means of promoting necessary behavioral change and stress reduction for recovery in FHA patients. Behavior change alone is not always successful and is not always possible, for example, in elite athletes. 6 to 12 months of behavior modification is encouraged before turning to drug treatment, as this is about how long it takes for amenorrhea to begin compromising bone health. The most common drug treatment is oral contraceptive pills, but this therapy is not supported by evidence, as oral contraceptive treatment was shown to increase recovery time and lack a protective effect on bone loss in FHA patients. The most current drug treatment recommendation is short-term use of transdermal E2 therapy with cyclic oral progestin. However, like oral contraceptives, this treatment still does not address the underlying cause of FHA or the other hormonal disturbances and health consequences associated with FHA, so behavior modification should still be the primary focus if possible. Additional therapies that are currently under investigation include leptin and kisspeptin. The recommended treatment for women with FHA wishing to conceive as soon as possible is pulsatile GnRH, or, when GnRH is not available, gonadotropin therapy and induction of ovulation. It is important to note that the induction of ovulation is only suggested for women with FHA that have a minimum BMI of 18.5 and have attempted to normalize energy balance.